Hi, I'm Dr. Kerry Sanders. I'm a board-certified orthopedic surgeon at Centennial Orthopedics. Today I want to talk about total knee replacement, and during this presentation I'm going to talk a little bit about total knee replacement as a procedure, but also I want to go through several questions that my patients routinely ask during our discussions about total knee replacement. Total knee replacement is a resurfacing operation for patients whose joints have deteriorated to the point that the pain is no longer manageable for them. So in this segment I want to briefly discuss what the procedure is. This is a model of a total knee replacement, and basically what you can see in this model is that the end of the femur bone has been resurfaced with this cobalt chrome cap, if you will. Also you can see that the end of the shin bone, or the tibia, has been resurfaced. In their places, after a small amount of bone is removed, these metal implants are cemented into position using a special bone cement that acts like a grout that secures the implant to the bone. Not shown in this is the kneecap, which sits right in this groove, and the kneecap also is resurfaced with the same type of plastic that you would see here. After the completion of a total knee replacement, the bearing surface of the knee, instead of being cartilage on the femur and tibia, is now cobalt chrome and polyethylene plastic. And that has proven over the last 30 to 40 years to be a very good, reliable bearing surface. Many patients ask me what the indications are for total knee replacement. This is a very important consideration as you're thinking about having a total knee replacement. The indications, or the time at which it's appropriate to replace a knee, has to do mainly with two basic questions. And that question is, number one, how badly does it hurt? Many patients have pain, but how much pain? Well, only the patient really knows that answer, because you're the only one experiencing that pain. The second question is similar in the sense that it's individual, and that is, what do I want to do that I can't do anymore? Those two questions form the core of why a person would consider having their knee replaced. Typically, a person who's considering knee replacement has already undergone numerous non-surgical treatments. They've maybe tried medications or injections. They may have tried therapy or bracing. Numerous treatments are out there for non-surgical care of the knee. But at the point at which none of those things are working, the patient may consider having their knee replaced. And the question of how much does it hurt, but also what kinds of activities is this keeping me from doing, are really the core of what make up that determination. Together, as the surgeon and the patient, we make that decision together as an individual, on an individual basis. Many patients want to know who is not a candidate for knee replacement. There are several factors that affect the safety of having your knee replaced. And it's important to remember that as we consider those factors, that a knee replacement is an elective operation. That means that basically the patient is deciding to have this done, and it is not a life-saving treatment. So things that oftentimes get in the way of a patient getting their knee replaced. One of the more common issues has to do with patients' weight. Oftentimes patients are struggling with their weight at the same time they're struggling with their knee arthritis. As their activity has been going down, their weight has been going up. And that's a significant struggle. It also is a significant struggle in the outcome of the operation. One of the things as a surgeon that I really want to ensure is that we're maximizing our chances for success and minimizing our complications or potential for complications in having an operation. Certainly being significantly overweight is one of those determining factors that places people at higher risk. We typically use a body mass index as a cutoff. Historically, the number 40 has been our cutoff for whether or not to do a knee replacement based on weight. The second thing that commonly happens is patients have fairly profound medical issues that stand in the way of having their knee replaced. Oftentimes, in aging populations, there are other medical conditions that are of significance. Sometimes those medical conditions are just too risky to undergo a very major operation such as knee replacement. And so unfortunately we have to elect not to have a surgery in those instances. Very often, however, patients can be optimized or sort of tuned up, if you will, by their heart doctor or their primary doctor, get their things like blood sugars under control or get their heart in the best shape possible to safely undergo the operation. And sometimes that takes a little patience as we work through that and prepare the patient for knee replacement. Many patients ask about how age affects our decision-making process in total joint replacement. Although age is a consideration, especially as we consider medications to give and how we treat patients through the operative process, age in and of itself is not a major determinant. What is a major determinant has to do with their medical stability and their issues and how well they're controlled. I've had numerous patients in my practice that are in their late 80s or early 90s that are quite healthy and are actually great candidates for knee replacement. These are the types of patients who have everything to gain from the operation and frankly very little to lose oftentimes. Sometimes those patients see their independence threatened by their knee or hip pain. And so a total joint replacement actually is a very logical thing to consider because basically they're quite healthy and they have a lot to lose if they continue to lose their mobility. So age, although it's a factor, is not the primary factor that we consider when we're evaluating a patient for knee or hip replacement. I think most all my patients that come in have known people that have had knee or hip replacement, and the benefit of knee and hip replacement is that it tends to be a long-lasting solution to a long-lasting problem. Most of our patients that come in for knee or hip replacement have been dealing with severe pain for several years, oftentimes decades of pain as it's progressed worse and worse for them. So the benefits basically are that it is a fairly predictable way to treat this, and it is a long-lasting remedy for it as well. Certainly, total knee replacement has some significant risk to it. This is a major operation, and as such, you can have major complications. Many patients will ask what those risks are. Certainly the big risks, the risks that are most feared by guys like me, are going to be infection and blood clots, because those tend to have the most severe outcomes when they're encountered. The other one that I worry about with knees especially is stiffness and persistent pain. So let's talk about each of those briefly and what they mean and what we can do to prevent them. The first let's talk about is infection. Infection is about a 1% risk or so, a little bit higher in patients who have diabetes or have other reasons that their immune system wouldn't be quite as strong. So in the preparation for total knee replacement, we do a variety of testing. to see if patients are colonized with more aggressive types of bacteria. We give antibiotics around the time of the surgery. We wear special operating attire that covers our entire head and face in its entirety as well. So there's, in addition to the usual precautions we take to prevent infection, there are some extra steps that we take prior to total joint replacement. In the unfortunate chance that an infection does present, especially if the infection goes on to be a chronic infection or is deep in the tissues, the outcomes can be pretty severe. In those cases, the implants have to be removed, and the patient has to go a period of antibiotic treatment before the implants can be replaced. That's pretty rare. Most often, if there is an infection, the infections tend to be above the level of the muscles and tend to be fairly treatable. Next, let's talk about blood clots. The inflammation around the knee at the time of surgery can increase the likelihood of blood clots. There's been a great deal of attention given to this problem and how to prevent it, but also how to treat it. So, in basic terms, we know that if we thin the blood, that helps to prevent it. We know that if the patient will be more active, that also helps to circulate that blood and helps to prevent blood clots. We also know that blood clots can run in families, and we try to ensure that before we undergo the surgery that we've asked about blood clots in the family and whether anyone in the family, meaning mom, dad, brothers, sisters, and even maybe uncles or aunts or grandparents have ever had a blood clot, especially a fatal blood clot. Those questions are very important because it may help us decide to be a little bit more aggressive in how we try to prevent that with some blood thinners. The downside to blood thinners, of course, is that blood thinners can cause bleeding complications. Both in the surgery wound, it can create a lot of bleeding that then, of course, prevents motion and increases pain, but it can also cause bleeding in other areas, such as the stomach or the brain, and those can have devastating complications as well. So you can see the difficulty with trying to treat this. The treatment itself presents some risk. To not treat also presents risk. So blood clots are something that we have to watch very closely. About 1 in 1,000 or so patients can have a fatal blood clot after a total knee or total hip replacement. The risk of getting a blood clot does not necessarily mean that you would die from it or even have any complications from it. In fact, it happens that small clots evolve very frequently, but they never become significant or meaningful to the patient, which further makes it difficult to know which ones are meaningful, which ones should we treat, and how aggressive to be with it. So just because a patient may have had a small clot doesn't necessarily mean that their life was threatened or that there is a bad outcome that is certain to follow. But it certainly makes us anxious as the surgeons. Finally, let's talk about stiffness. This is a much more common complication. About 80 to 90% of total joint replacements have great outcomes, depending on which studies you look at. In my opinion, when we look at those patients and we look at that 10 to 20% of patients that aren't as happy as they wish they were about their knee replacement, the number one factor that stands out in my experience has been knee stiffness. What you do after surgery, and I'll talk a little bit more about this later, the patient's role in therapy and aggressive activity is critically important in the outcome of this operation. And stiffness frequently presents in patients who had difficulty accomplishing their physical therapy, typically due to pain. And so that is a risk. Oftentimes patients who think they're not going to have any problem with this tend to have a struggle with getting through their therapy. And so we take that pretty seriously. We have a whole program of therapy designed to help prevent stiffness after a total knee replacement. But suffice to say that a stiff knee doesn't feel good. It doesn't feel natural and it doesn't move well. And so stiff joints in my experience, never feel good. They never feel normal, and they almost always are accompanied with pain. Total knee replacement has about an 80 to 90% good and excellent outcome track record. It is one of the best surgeries designed in the 20th century. It's very reproducible, especially in doctors who do a lot of it. Good and excellent outcomes are very common. So total knee replacement has a very good track record with around 85 to 90% good and excellent outcomes. The patient's role is critical after a total knee replacement is done. I always like to tell the patients, my part's easy, I just put the parts in. And after I'm done, you have to do all the hard work. And that's really a lot of truth to that. Basically the patient and the physical therapist and the nurses after surgery have a very, very important role to play in the success of this operation. It's critically important that the patient be prepared mentally and emotionally for this operation, because they have to have it in their heart and mind that they're going to get up and go right after surgery. It's expected that the patient will get up and walk the same day of surgery and get out of bed and start taking some steps, maybe go for a short walk with their nurse or with their physical therapist. So basically, your role also extends into being my eyes and ears. Of course, when you leave the hospital, I'm not going to be with you, and my nurses won't be with you. So I expect you to help me to keep an eye on things. If there's redness or swelling that looks unusual or worrisome, if there's significant drainage from the wound, you need to let us know. And you need to be cooperative to the therapist. Sometimes the therapist will push the patient. I had a patient complain to me once and said, "These therapists are too pushy." And I said, they're supposed to be pushy. I tell them to be pushy. I encourage them to really push our patients, because I really want you to have a great outcome from this. I want the patients to come back, at 2 weeks and 6 weeks after surgery and say, hey, I'm doing great. And the way that you'll do great is by working hard in physical therapy. If you don't work hard, you're not nearly as likely to have a good outcome. And that's really, really important. Patients often are a little bit intimidated by the process that leads up to total knee replacement or total hip replacement. At Centennial Orthopedics, we have a surgery coordinator who is responsible for preparing patients for surgery, and they'll help you through this fairly complex process of getting preoperative clearance and getting everything ready so that you will be prepared on that day of surgery to have your knee or hip replaced. In addition to that, we have classes that we really encourage our patients to attend because they will help you see where you're going, they will help you to understand what is expected of you, and also what you can expect of the nurses and the other skilled personnel that will help you through this process. After surgery, the patient will go to their hospital room, which is typically on the second floor in the orthopedic unit, and we have nurses who are trained in orthopedic care specifically. It's expected that you'll get up and do some walking the day of surgery, and typically our patients will get up at least 6 times per day that they're in the hospital. Once in the morning and once in the afternoon with the physical therapist, and then at least a couple walks with your nurse or tech in between those therapy sessions. So patients, when they go home is dictated by how quickly they're recovering. Some patients will go home the next day after surgery. Some patients will go home the second day after surgery. It's pretty rare for patients to go home after that unless there's some other issue going on from a medical standpoint. So upon discharge, you'll go home. Typically, we have home health arranged so that they will come to your house, and for the first 2 weeks after surgery, you'll do therapy at home with a home health nurse and or home health therapist, and they will, help manage your wound. They'll help get you going with your exercises and do all of that without having to get you out in a car and make it to therapy. Some patients I've had request to begin outpatient therapy immediately after surgery, after discharge, and that's okay too. I'm not against that at all. But most of our patients appreciate being able to do that at home because of the difficulty getting in and out of a car and getting to and from surgery, to and from therapy. So patients will ask questions such as, how long does it take to get over this? It's about a 2-month recovery typically, and I define recovery as the point at which you're getting around without assistance and not entirely pain-free, but your pain is becoming less and less of a consideration. Maybe you'll have a day or a period of time during the day when you forgot altogether that you'd even had your knee replaced. Your pain is diminishing in a steady way, and you're able to return to a majority of activities such as shopping and getting out and into the community. Some people recover much quicker than 2 months. Some people are basically done in 4 weeks or 6 weeks. Some patients will take a little bit longer. Oftentimes patients will continue to have some level of stiffness in their knee for a period of months afterward. We call that startup pain. And startup pain basically is those first few steps you take in the morning or the first few steps you take after you've been in a car for an hour or so and your knee's a little bit stiff. The startup pain has to do with the scar tissue around the knee maturing and turning into a more sophisticated version of scar tissue, and it tends to lessen over time. And finally, people ask about when can they drive again as far as in the postoperative period. Again, some of that will depend on whether you have a right knee done or a right hip, or a left knee done. That basically, and it also depends on whether you have an automatic transmission or not. I don't tell my patients a particular day that they're prepared to drive. And the reason for that is the results vary from patient to patient in terms of how quickly they can get their foot from the gas to the brake. Some studies have said that it takes up to a couple of months for that to return to be as quick as it was before surgery. I think patients are smart enough to know when they're safe to drive a car. I always make it clear that patients cannot be driving while under the influence of narcotic pain medication, but otherwise they have to use their best judgment as to when they feel safe and it's appropriate for them to drive again after total knee replacement. So in conclusion, I want to thank you for taking the time to watch this video about total knee replacement. In summary, total knee replacement is a great operation for patients who have unmanageable knee pain and have not had any meaningful success with the non-surgical treatments. Finally, if you have any questions, please don't hesitate to contact our office at Centennial Orthopedics. Our office number is 541-229-2663. Thanks a lot.